Hello, and welcome to Chapter 18, Cardiac Emergencies for the EMT. So in this lecture, we're going to talk about cardiac anatomy and physiology. We're just going to review it just a little bit. Acute coronary syndromes, um, causes of cardiac conditions, and cardiac arrest. So let's review some cardiac anatomy and physiology. So when we talk about blood flow through the heart, we talk about the fact that the blood comes from the body, okay, where it was oxygenated before. It's a cycle, okay, and it comes back to through the superior vena cava and the inferior vena cava to the right atrium, to the tricuspid valve, to the right ventricle, and then it goes off to the pulmonary artery. It goes off to the lungs, where the carbon dioxide gets exchanged for oxygen, and then it comes back through to the pulmonary veins, and goes into the left atrium, through the mitral valve, to the left ventricle, and then it gets pumped out to the aorta through the rest of the body. Okay. The cardiac conductive system, remember that's our electrical system. We start at the top of the heart. This is what pumps the heart, makes the heart pump. We start at the top of the heart with the atrial bundle, and that AV node, the atrioventricular node. So it starts at the AV node, goes out to the SA node, and then down through the bundle of His and the Purkinje fibers and all of that stuff. And if we've got an electrical problem, then you need an electrician, right? If you've got something that deals with those chambers or the veins or the vessels, then you've got a plumbing problem and you need a plumber. Okay. So composition of blood. Remember, we've got white blood cells, red blood cells, plasma, platelets. All of that stuff makes up the heart. Plasma makes up a big part of it. That's what the fluid is that comes through the body. Okay. And then, of course, the flow of blood through the arteries, veins, arterioles, venules, and capillaries. So arteries go away from the heart, veins go to the heart, except in the case of the pulmonary arteries and the pulmonary veins. The pulmonary arteries go towards the heart, and the pulmonary veins go away. But so what happens is you've got all of your arteries, and they progressively get smaller. So you go through the aorta to the descending aorta to the abdominal aorta, and from the abdominal aorta, it filters out to the rest of the body. Okay. So, and they get smaller and smaller. So from the aorta to the arteries, to the arterioles, to the capillaries, and then the capillaries is where it gets exchanged from all of the body, all of the stuff where it needs to go, because the blood is the transport system of the heart or the body. So what it does is it comes down, goes through the capillaries. It gets exchanged with all the bad stuff, the carbon dioxide, anything that needs to be wasted through the kidneys, through the liver, anything. So it all goes out, and then after it goes out, it goes back to the veins, or to the venules, and then the veins, and then the inferior vena cava and the superior vena cava. Okay. Circulation of blood between the heart and the lungs, and between the heart and the rest of the body. We just talked about that a little bit. You know, that blood goes to the lungs. It gets filtered, goes to the heart, and then out to the rest of the body with oxygenated blood. Function and circulation of blood relate to pulse and blood pressure. So the pulse is how many beats per minute, the electrical system, that the body is producing. Okay. Blood pressure is how much ejection is coming out of the heart. Okay, does that make sense? So pulse is electrical and blood pressure is plumbing. All right. And then shock. So shock, that hypoperfusion. If we don't have enough blood going around to the rest of the heart, then we're going to go into shock, which is called hypoperfusion. It can be caused by the veins either constricting or dilating, where when they're dilating, there's not enough fluid. There's not enough fluid to go through those that plumbing. Okay, and if there's not enough fluid, then then the body says, hey, I need more fluid, and it can't do that. So it's just going to be, you've got this amount of fluid with this huge plumbing, and it's just not enough. Okay, so so dilated vessels, you've got not enough fluid. So somewhere down the line in the body, there's something that's happening that says, hey, I'm losing fluid, either through bleeding, internal bleeding or external bleeding, and it's just saying, hey, I can't do anything. Okay. So the four chambers of the heart. Okay, so we've got the left ventricle right here, the right ventricle, the right atrium, and the left atrium. Okay, so blood flow through this comes from here and here, and it goes right into here. Okay, and then it goes down into here, and then it goes right here. Okay, and it goes out to the lungs, out to the lungs, and then from here it comes back from the lungs here and here, and it goes into the left atrium, and then it goes through the mitral valve to the left ventricle, and then it goes out to the aorta. Okay, and then down to the rest of the body. Okay, these go up to the brain. All right. Okay, so we talked about this. So how does the normal function of the heart and blood vessels relate to blood pressure and distal pulses? We talked about it. You've got to have an electrical system to create that pulse. You've got to have enough blood to get down there to say, hey, you know, my pulse is bad down here. I need some more blood. And blood pressure. How is shock related to the function of the heart and blood vessels? We talked about that. Okay, so that if we've got vasodilation where the blood vessels are huge, there's not enough fluid to go through them. Okay, and sometimes we have normal vessels, and those vessels are just normal, but there's not enough fluid to go through them. All right. So let's talk about some acute coronary syndrome. This is sometimes called cardiac compromise. Refers to any time the heart may not be getting enough oxygen. There's many different kinds of problems under the ACS heading. It can sometimes often mimic non-cardiac conditions, and we're going to treat all patients with ACS like signs and symptoms as though they're having a heart problem. Okay. So chest pain is the best known system. It can be described as crushing, dull, heavy squeezing. This crushing one right here really says a lot. I've had lots of patients tell me that they feel like an elephant is sitting on their chest, and they tell me that it's sometimes like unbearable. Okay. So sometimes described only as pressure or discomfort. Again, that pressure. and it radiates sometimes down along the arms, down to the upper abdomen or up to the jaw. Females are a little bit different. They can have uh, uh, pain in their upper back. They can sometimes just have jaw pain. I know that when we talk about acute coronary syndrome, it's an ALS thing. Okay, you need ALS to start the process, because we do a 12 lead, we give them nitro, we give them um, aspirin. So all of those things go into what we call the Mona mnemonic, which is kind of getting out of the way, but morphine, oxygen, nitro, and aspirin. Okay, so that's Mona. Mona is one of those things that almost every single patient gets. We don't carry morphine on the truck anymore, so we have Dilaudid and fentanyl and various other things, but it's just a pain med. So all of those things will work. Okay, morphine typically works the best, but it's just a pain med. All we're doing is trying to take away their pain, and if we can do that with fentanyl or Dilaudid, then hey, great. Okay, but again, this is not true for everybody. Okay, so sometimes they will just have like arm numbness or tingling, which then you've got to figure out your differential diagnosis. Is it a stroke or is it a cardiac problem? Okay. Dyspnea is also found in ACS, and it may be the only finding in some patients. When we have a patient with difficulty breathing, then yeah, we need to run a cardiac workup on them to make sure that it's not cardiac, okay? Because of the fact that dyspnea is also found in this set of problems. Okay, so other symptoms: anxiety, feeling of impending doom. When you have a patient that tells you, hey, I don't feel good, or they start making requests of, please tell my family I love them, I feel like I'm going to die, tell my family this and that, then you really need to start thinking some type of cardiac problem. Okay, these patients are probably on their last little bit, and you need to step it up with your treatment. You need to start thinking about the fact that this patient could code at any time. I've only had one patient tell me that they felt like they were going to die and then died after they went into cardiac arrest afterwards. But it's a serious thing when these patients start doing this, okay? Nausea and pain or discomfort in the upper abdomen. So yeah, they typically have some type of nausea. They don't necessarily have vomiting, but they do have nausea. And that's really caused by pain or discomfort. It's not like a symptom of the cardiac problem itself. It's a secondary symptom of the pain, okay? Sudden onset of sweating. Yeah, they're going to be diaphoretic. Your classical patient who presents with a cardiac problem is going to be pale, diaphoretic. They're going to have nausea. They will have some type of anxiety. They'll have that chest pain that radiates into the left arm. They'll have all of these things, and that's your typical textbook chest pain, cardiac syndrome. So MI, okay, myocardial infarction. So all of these things are going to go into everything, go into your diagnosis, all right? So when we do a patient assessment, we're going to perform our primary assessment. Remember, ABCs first, airway, breathing, and circulation. If I don't have any of those things, I can't fix anything else. So you've got to have your airway, you've got to have breathing, you've got to have circulation. Again, I can't fix anything else unless those three things aren't there. So then we're going to obtain a history and physical exam. In our history, we're going to ask them specific cardiac questions. And remember, in our differential diagnosis, when we talk about this, they've got difficulty breathing. So we've also got to do a respiratory history as well. So you've got to figure out, is this respiratory or is this cardiac? It's cardiac until proven otherwise. If their breathing is semi-okay, they're just in distress, or they're just having difficulty breathing, and they're not in like failure. All right. So obtain a history. So we're going to talk about previous cardiac events. A big one is when you take off their shirt and you see stitches or scar down the middle of the chest. That's what we call a zipper, and that zipper is indicative of some type of heart surgery. Okay, typically it's open heart surgery. It's that like a cabbage, or they've had a bypass or something like that. Okay, so in our physical exam, what we're going to talk about is, or what we're going to do is, we're going to assess their pulse. I want hands on that pulse, that radial pulse, because you need to feel it. Okay, cardiac patients need that. You need to be able to feel it, so that way you can determine the rhythm and the quality. Because you can't get those things from a pulse ox. It's easy to do. We don't necessarily do it all the time, but you need to be able to assess their rhythm and quality by touching the patient. You have to touch your patient. There's no getting around it. So also in our physical exam, we're going to talk about, we're gonna assess their lung sounds. Remember, we've got to determine whether or not this is cardiac or respiratory. So we're going to listen to lung sounds. We're going to listen to heart sounds if you want. For you guys, it's not that big of a deal. But heart sounds are, that lub dub, lub dub, lub dub, lub dub. That's normal. That's pretty much anything outside of that range is an abnormality. So yeah. And then to go along with their history, look at what kind of meds they're on. Cardiac patients will typically be on a set regimen, and it varies by doctor on the specific medicine, but the kind of medicine is there. Okay, so those antihypertensive, maybe some blood thinner. They may be on a rhythm disturbance drug. So like cardizem, lidocaine, not lidocaine, but cardizem, and any kind of other anti-dysrhythmic drug. All right. Use the OPQRST to get a history of the present illness. So remember, onset, provocation, quality, respirations, radiation, severity and time. Get that OPQRST to get that history of the present illness. And then obtain your past medical history. Again, this kind of goes into the history and physical. And then take your baseline vitals. Patient care, we're going to place the patient in a position of comfort, typically sitting up. They don't want to lay down. Determine if oxygen should be administered. Remember, we're looking at that 94 percentile and lower. We're going to at least give them some type of oxygen, and then transport. Okay, so provide high concentration oxygen by non-rebreather mask if necessary, and then perform that physical and history. So if trained, equipped, and authorized to do so, obtain a 12-lead ECG. So here is the deal. We are not going into how to interpret a 12-lead. However, You guys can do a 12 lead and transmit it to the hospital if you're like on a BLS truck. All right, so what you're going to do is you're going to just do that 12 lead. We'll go into it. I'll teach you how to obtain a 12 lead, but you can't interpret it. All right, you can't interpret anything on the monitor. You can't do anything like that. So you're going to put them on the monitor and obtain a 12 lead, and then you can transmit it to the hospital, just to kind of give them a heads up if you think it's cardiac. Even if you don't think it's cardiac, it's probably not a bad idea if you're on a BLS truck to go ahead and obtain that 12 lead. All right, so nitro. So indications for administering nitro. Remember back in chapter 16, we talked about some of these things. So chest pain, history of cardiac problems, and is the prescribed nitroglycerin. The physician has prescribed nitro to the patient, and the patient has the nitro with him. Remember our 5 rights to patient administration of drugs. Okay, so this is nitro tablets. This is typically what they'll take. It's 0.4 milligrams. That's the dose. It doesn't ever change. No doctor is going to prescribe more unless it's through an IV. And even then, it's not going to change. So this is the dose. And it's sublingual. So remember that goes up underneath the tongue and gets dissolved up underneath the tongue. Okay. Some more indications. So systolic blood pressure meets protocol criteria. So remember, their systolic blood pressure needs to be at least 100, 90 to 100, I believe, to be able to give nitro. So I want that blood pressure up and good before I can give that nitro. And even then, I'm very cautious on a patient's blood pressure that's lower than 100. I would prefer that I get an IV before I even start thinking about nitro, because what does nitro do? It's a vasodilator, and when you've got all of that blood, that now just basically goes away. All right, so their blood pressure is going to drop. You're not going to be able to find a vein very easily. So before I give nitro to a patient who's got a systolic less than 100, I want an IV started. Patient has not had Viagra, Cialis, or anything like that for erectile dysfunction within the last 48 to 72 hours. Viagra and Cialis, those are all vasodilator drugs. Because what does it do? It vasodilates and it rushes blood to where it needs to go, because all of those veins are constricted or they're normal size. So where's it all going to go? It's going to go to the penis. Okay? So all of that blood has now, done its job, but we need to be able to be we don't want to give them like a whole lot of vasodilators within a short time frame. And then medical direction authorizes the administration. Okay, so after giving 1 dose of nitro, repeat the dose if the patient experiences no relief or only partial relief, systolic blood pressure remains greater than 90 to 100, and the medical direction authorizes another dose of medication. Again, this right here, I would be very cautious in giving a patient another dose of nitro if their pressure is at 100. Okay, my personal preference is that I don't give nitro to a patient that doesn't have a blood pressure, or I'm sorry, I don't give nitro to a patient who doesn't have an IV already. I would prefer to be able to start the IV first and then give it, unless the patient is just in pain or they have a very high blood pressure. So like I'm talking high, like 200 systolic and more. And then I'll go ahead and give it just because it's not going to drop that much, but it will drop. Okay. So indications for administering aspirin. Chest pain, the patient's not allergic to aspirin. There's no history of asthma. The patient's not taking any medications to prevent clotting. Again, we talk about aspirin being a blood thinner. It's really not. It's more of an antiplatelet, and it prevents clotting. Okay. So no other contraindications to aspirin, medical direction, authorization. Another contraindication to aspirin would be the fact that they had some type of recent bleeding, like stomach ulcers, esophageal varices, any of those things. We don't really want to give aspirin, and you want to make sure that you are cautious in a patient who has asthma, because aspirin can precipitate asthma. So we want to be cautious in those patients as well. Okay, so this is the aspirin. Again, the dose is 81 milligrams, and we're going to give 4 of them to equal a total dose of 324. We want it the chewable aspirin. We need it the chewable aspirin. Okay, so that way they can chew it. And this is given buccally, so when they chew it, it gets absorbed through the cheek, the lining of the cheek, and gets that way. Okay, so causes of cardiac conditions. Heart problems caused by a number of disorders affecting condition and function of the blood vessels and the heart. Okay, so there's conditions that narrow or block the arteries of the heart. This often results from fatty deposit buildup on the inner walls of the arteries, so like atherosclerosis or atherosclerosis. Okay, so the buildup narrows the inner vessel diameter, restricting blood flow. So a thrombus, this is an occlusion of blood flow caused by the formation of a clot on the rough inner surface of the diseased artery. It can break loose and form an embolism. Again, this is kind of like that PE, that pulmonary embolism that we talked about. When patients they sit for a long time after surgery, all of those blood clots form because the blood isn't flowing. So that patient gets that clot, it breaks off, it goes up to the pulmonary system, and the pulmonary system gets that clot in it and becomes an emboli. So what happens in the heart is, remember those coronary arteries that supply blood to the heart itself? So those coronary arteries get a clot in them. They get a clot in them, and what happens is that those clots can then break off. They can go downstream and occlude a smaller artery, and then what it does in the coronary arteries is that it occludes that smaller artery, and then all of that tissue dies within a matter of minutes because that blood flow has to be there. So reduced blood supply to the myocardium causes an emergency in the majority of cardiac related emergencies. Again, got to have coronary blood supply, because if you don't, it's a muscle. It's working overtime to be able to get what it needs to get done. Okay, so chest pain is the most common symptom of reduced blood supply to the coronary arteries and to the myocardium. So an aneurysm is when you have weakened sections of the arterial walls, and then they begin to dilate. So your normal blood vessel is like this, or coronary artery is like this, and then what happens is that vessel just kind of expands, and then when it can burst, and cause rapid, life-threatening internal bleeding. Okay, so this is an aneurysm. When we talk about an aneurysm, this is that bloating, that expansion, and then it bursts. You can have a AAA, an abdominal aortic aneurysm, and that, remember, that's that aorta that runs through the middle of the abdomen, the abdominal aorta, and then it feeds all the blood supply off to the tissues around it, the organs, everything like that. Sometimes that AAA will pulse, and if it pulses, don't touch it. Move your patient very gentle, because when it's pulsing, that means that it's going to get ready to burst. And then you've got internal bleeding, and your patient's probably going to die pretty soon. Okay? You need surgery. So let's talk about electrical malfunction of the heart. Remember, we just talked about plumbing. So now we're going to talk about electrical and the fact that we need an electrician to fix stuff. So this is a malfunction of the heart's electrical system. It generally results in some type of dysrhythmia or heart rhythm problem. Okay, so dysrhythmias include bradycardia, tachycardia, and rhythms that may be present when there is no pulse. Okay, when we talk about those rhythms, we talk about like pulseless VTach, ventricular fibrillation. Those two things, if you remember when we did CPR, those two things are what the AED looks for and can shock. Okay. So mechanical malfunctions of the heart, angina pectoris, acute myocardial infarction, and congestive heart failure. These are things that where that mechanical problem is having an issue. Okay, it's not necessarily the plumbing or the electricity, but now we've got the parts itself. All right. So angina pectoris, there's a chest pain caused by insufficient blood flow to the myocardium. This is typically due to narrowed arteries secondary to coronary artery disease. Remember that coronary artery disease is where the plaque builds up inside the artery and then it breaks off and goes down to the narrow arteries. All right. Patients can live with coronary artery disease for years and never have a problem, but sometimes they do. And what happens is this pain usually comes on during in times of increased myocardial oxygen demand, such as exertion or stress. Okay. Acute myocardial infarction. This is a death of a part of the myocardium due to the lack of oxygen. Coronary artery disease is usually the underlying problem. So remember, we've got angina pectoris, where it just kind of breaks off, it goes down, that plaque buildup breaks off, goes down to the narrow arteries, and the narrow arteries then become blocked when they exert themselves, they exercise, they do some type of stress-induced type deal. And then with an AMI, it goes further where it's not just during exertion or anything like that. What's happening is that plaque that has come off caused the emboli, and now it's down into the narrow arteries, and it's sitting there, and all it's doing is causing coronary artery. It's causing coronary arteries to not be able to flow blood to the rest of the heart. All right, so this is that acute MI. This is the dead area of infarct. Okay, so if you look here, we've probably got some type of blockage down through here or here. And it just kind of depends on where the blockage is. But all of that blood flow has stopped and it's causing this tissue of the heart to die. Okay, so this is an inside look. This is that dead tissue. Congestive heart failure. This is inadequate pumping of the heart, and it oftentimes leads to excessive buildup in the lungs and or the body. It can be brought on by disease of the heart valves. It can be brought on by hypertension, obstructive pulmonary disease, and it's often a complication of an acute MI. So progression of CHF, the patient sustains an acute MI. The myocardium of the left ventricle dies. So left ventricular heart failure is typically what we see. Because of this damage, the blood backs up into the pulmonary circulation and into the lungs. And if untreated, the left heart failure commonly causes right heart failure. Okay. Signs and symptoms: tachycardia, dyspnea, cyanosis, normal or elevated blood pressure. Typically, these patients will have an elevated blood pressure, especially when they have like a CHF exacerbation. They'll have that elevated blood pressure because their anxiety is through the roof. Diaphoresis and pulmonary edema. Anxiety or confusion due to hypoxia. Pedal edema, engorged pulsating neck veins. This is a late sign, which we call JVD. Enlarged liver and spleen with abdominal distension, another late sign. Okay. All right, so let's talk about cardiac arrest. Chain of survival. So there's 5 elements: immediate recognition and activation, early CPR, rapid defibrillation, effective advanced life support, and integrated post-cardiac arrest care. And then we've got teamwork and coordination. Okay, so immediate recognition and activation, this requires prompt notification of EMS and will most likely be a bystander without any kind of CPR knowledge. Early CPR increases the chance of survival significantly. There's 3 ways CPR can be delivered. You get trained CPR professionals to the patient faster. So like your first responders, your fire department, anything like that. We train lay people in CPR. This is huge. I've been on patients where I've had lay people trained in CPR and where there was no CPR in progress even when I got there. And the CPR that was started before we got there, when the patient went down, we helped tremendously and actually got a return a pulse. We also do, with this training the lay people CPR, in Missouri, there is now a requirement that all graduating seniors have a CPR course or be trained in some type of CPR. Okay, so you're going to see more and more people out there having CPR. And then we can also train our dispatchers to instruct callers on how to perform CPR. They do it all the time. If the bystander is comfortable with doing it. High performance CPR. Okay, so changes implemented in resuscitation efforts. We're going to compress the chest at least 2 inches in adults, allowing for that full relaxation on the upstroke of compressions. So full recoil. We're going to allow that chest to fully come up and relax, and before we go back down. And then spinning half of each compression on the downstroke and half on the upstroke. Using correct hand position. Remember, we're going to go right here in the middle of the chest, right between the nipples, and right on the sternum. Compress at least 100 to 120 times per minute. and spend no more than 1 second on each ventilation, minimizing interruptions of CPR to no more than 10 seconds. Okay, the key is to increase cardiac output. And since most cardiac arrest in adults are the result of cardiac problems and not respiratory problems, there's enough oxygen in the bloodstream to maintain that metabolic process for several minutes. Okay, so rapid defibrillation, the sooner the defibrillator arrives, the more likely the patient will survive in cardiac arrest. So when a patient goes into cardiac arrest, what happens to their heart is the heart says, hey, I'm giving out. The body says, hey, I'm giving out. So the heart just kind of stops. But what it does before it stops is it goes into ventricular fibrillation or pulseless ventricular tachycardia. Okay, so when it goes into one of those two rhythms, excuse me, what it does is that AED is what recognizes those two rhythms, and before the patient actually goes into asystole, or that flat line where you see like on movies and various things like that, where they always shock it. You can't shock asystole, unfortunately, although there have been a couple studies out there where they have talked about doing that. Anyway, so what it does is the sooner you get that AED to that patient, and the sooner it can recognize one of those rhythms, because the heart doesn't just automatically go into asystole, it goes into one of those rhythms first, and then it goes into asystole. So the sooner we get that defibrillator on scene and to that patient, the better chances they have of surviving cardiac arrest. Okay, so this is rapid defibrillation. I'm not going to go detail by detail. I'm just going to go through the slides. So this is how you use the AED. Sorry, I thought it was going to go. So effective advanced life support, generally provided by the EMT paramedic who responds to the scene or rendezvous with a BLS unit en route. Rapid transport to the hospital may be the most time-efficient means of obtaining ALS. So even as a BLS unit, I would stay on scene until you got an ALS unit there. We typically do not transport cardiac arrest anymore, just because there's not anything proven that says they have a greater chance of survival if they get transported. If you're on a BLS unit, it might be a little bit different because you don't have a paramedic there to perform the ALS procedures that need to be done. But if you're on an ALS unit and you go to a cardiac arrest, they're not going to transport. They're going to work the call until they get a return of pulse and then transport. It's just an AHA guideline that we're not going to be there. The hospital isn't going to do anything that we aren't doing. Okay, we have all the same tools, the same drugs, everything in the hospital is the same for us out in the field. We just don't have the amount of people that sometimes the hospitals have to run a cardiac arrest. Okay, so integrated post-cardiac arrest care. So after we get a pulse on the patient, this is coordinating numerous means of assessment and interventions that together maximize the chance of neurologically intact survival. So we're going to maintain adequate oxygenation. We're going to avoid hyperventilation. This patient probably is not breathing on their own still. So we still need to bag our patient. We're going to use the BVM to bag our patient. We're going to perform a 12 lead. We're going to find and manage any treatable causes of arrest. In the ALS realm, we call that H's and T's. And those H's and T's is basically a list of things that we're looking for that start with H and T, okay, that can cause cardiac arrest. We're also going to determine the appropriate destination for the patient, and then possibly induce hypothermia. So I hate the term hypothermia for this. It is more temperature regulated body control. Okay, so it's more temperature regulated. We're not going to really induce hypothermia, although in our realm we can't regulate their temperature very well. We have cold packs, we have ice packs, or we have heat packs on the truck, but all we're really doing is that hypothermia. Okay, so the EMT provides 2 links in the chain of survival: early CPR and rapid defibrillation. So there's usually enough oxygen in the bloodstream to postpone ventilations for several minutes while chest compressions are performed. Yes, you can. However, I wouldn't suggest it because when that medic gets on scene, we want that patient to be oxygenated as much as possible. Okay, and even if you were to transport, we want that patient to be oxygenated as much as possible. So when we talk about management for cardiac arrest, perform 1 and 2 rescuer CPR, 2 rescuer CPR if possible, 1 at the head, giving breaths and 1 doing compressions, and then you switch out every 2 minutes. Take standard precautions, use an AED, request ALS when available to continue the chain of survival, use a BVM device with oxygen. Use a flow-restricted oxygen-powered ventilation device. We do not have those on the truck. We don't. Okay. Lift and move the patients. Suction the patient's airway. Use airway adjuncts, and interview bystanders and family members. Okay. So types of AEDs. We've got the semi-automatic, which advises the EMT to press a button that causes the shock to go, and a fully automatic, which does not advise the EMT to take any action and delivers the shock automatically. These are not in use very often, just because of the fact that it doesn't advise you to push the button and make sure that everybody's clear. You've only got a few seconds to make sure everybody's clear before it shocks somebody. Okay, so the semi-automatic is the most popular. So they can be classified by the type of shock delivered. Monophasic, which sends a single shock from a negative pad to the positive pad, and a biphasic, which sends a shock in one direction and then the other. Okay, so AEDs work to analyze the cardiac rhythm to determine whether the shock is indicated. Remember those 2 rhythms that I told you about, the ventricular fibrillation and the pulseless V-tach. It looks at those and says, hey, we need to shock this. Let's shock it. And it shocks. Okay. So this is your treatment sequence. I'm not going to go a whole lot of detail into it just because it's in your book. And we talked about it when we did CPR, your BLS CPR. So how AEDs work. Most common conditions resulting in cardiac arrest are shockable rhythms. Again, that ventricular fibrillation or the pulseless ventricular tachycardia. Okay. So interrupt CPR only when absolutely necessary and for as short a period as possible. CPR must be paused for rhythm analysis and defibrillation. Otherwise, it's just going to pick up your rhythm and the CPR. If bystanders are doing CPR when you arrive, have them stop. Verify pulselessness, apnea, and absence of other signs of life, no longer than 10 seconds. The reason we have them stop is because sometimes they get worked up. And when I teach CPR, I tell them that if they're not sure whether or not they felt a pulse and your patient is, or the person is unresponsive, to go ahead and start CPR. They may hurt. It's not going to hurt them to start CPR if they're unresponsive. It's fine. Okay. So I tell them if they're not sure to go ahead and start CPR, because when you're in that situation, you're not sure if you felt a pulse or you didn't feel a pulse. And it's better to have that CPR started than it is to not have CPR because you're not sure if you felt it. Okay? So when we get on scene, we're the calm, cool, collected person that we are. And we need to verify that there is no pulse, that the patient is apneic, and that there are no other signs of life. Okay? So then we're going to apply the AED, bare the patient's chest, quickly shave the area if needed, and if available, use the pediatric pads on pediatric patients. And if you're going to use adult pads on a pediatric patient, do not overlap them. Okay? Again, these are things that we went over in your CPR class, or you should have gone over in a CPR class. So I'm not going to hit them too heavily. Just kind of read the slide. So use the AED, turn it on, attach the pads and cables then to the patient. Start CPR and analyze. Clear your patient and shock if needed. Oh, sorry. I can't go back, otherwise I would. So if an AED finds no shockable ECG rhythm, it will advise that no shock is indicated. PEA, asystole, resume CPR immediately. Anytime that you're not actively analyzing or shocking a patient, then you should be on that chest giving CPR, giving compressions and doing all of that. Okay. We want to compress at least 2 inches deep for adults and at least 1/3 the depth of the chest for infants and children, and allow for full chest recoil. Remember that rate should be at least 100 to 120. Rotate personnel through the compressor position to prevent fatigue. If the patient awakens or begins to move, we want to obtain baseline vital signs, administer high concentration oxygen, and transport. You may still have to bag them, but... So, general principles of the AED. One EMT operates the defibrillator while another does CPR. CPR must include high-quality compressions. Defibrillation comes first. And you must be familiar with the model of AED used in your area. Here at the lake, there's a couple different ones. There's a couple Zols out there, life packs. We use LifePak 15 monitors on the trucks. So if an establishment like the library has AEDs in each of their facilities, so if that library at the library they have the AED, they have a LifePak type AED, same manufacturer. So that LifePak, we can take out their connection from their AED and plug it right into our monitor without having to take the pads off and switch the pads out. So eye contact with the patient must be avoided during rhythm analysis. Pulse checks should not occur during rhythm analysis. You want to clear the patient. Be sure everyone is clear of the patient before delivering every shock. Check the batteries at the beginning of your shift and carry a spare. If you have delivered 3 shocks and are without backup, prepare your patient for transport. If an AED is often not able to analyze a rhythm accurately in a moving vehicle. So again, if you're transporting the patient, pull over, analyze, and then move on. Okay. So coordinate with ALS, notify as soon as possible. If the team arrives before you have finished the first shock, they should allow you to complete the shock. Your actions may depend on location of the arrest and ETA of the ALS team. So with other people, so let the operator of the AED complete the shock before you take over care of the patient. You may need to take the first AED to the hospital with the patient so data can be retrieved from the machine, and that is the case. Typically what will happen is if you go to like the library and the AED, they use their AED on the patient, what will happen is they will either send it with us to the hospital so that they can get that data, or they'll send it back to whoever they bought it from, and they'll send them a replacement. So kind of works out, but pretty good. So your protocols will dictate transfer of your care. So post-resuscitation care, if the patient has a pulse, we want to manage the airway, avoid hyperventilation, keep the defibrillator on the patient during transport in case the patient goes back into arrest, reassess frequently every 5 minutes, and consider that hypothermia protocol. So if the patient has no pulse, you'll still need to resume CPR. AED will have given you a no shock indicated message, and the AED may be prompting you to analyze the rhythm because it thinks that there is a shockable rhythm. So ensure adequate ventilation and oxygenation. Adjust the amount to no more than what is necessary to achieve that O2 sat of 94. Protocol may require you to place the patient in therapeutic hypothermia and use techniques of lifting and moving. So patients who go back into cardiac arrest, we want to stop the vehicle for transporting, resume CPR, have someone else to start CPR if the AED is not immediately available, analyze the rhythm as soon as possible, deliver the shock if indicated, and continue 2 shocks separated by 2 minutes or 5 cycles. Moving on. Okay, so witnessed arrest in the ambulance, there's no guarantee, but a very good chance of reviving the patient because you can defibrillate very shortly after your patient goes into a shockable rhythm. Stop the treatment, treat the patient like any other patient in cardiac arrest. Okay. Single rescue with an AED, apply the AED and defibrillate immediately once the shock is delivered or received. No shock indicated, begin chest compressions. After about 2 minutes, check the rhythm again and shock if needed. So contraindications, there's really not a contraindication to using an AED, except for like severe trauma, where even if you got a pulse back, it wouldn't do anything. So like decapitations or patients who have signs of death, okay? Significant signs of death like modeling or lividity or various things like that. Okay. Do not defibrillate a soaking wet patient. Dry them off at least a little bit. Do not defibrillate if the patient is touching anything metallic that other people are touching. Remove nitro patches before defibrillating, and verbally and visually clear the patient before defibrillating. Okay. Implants and surgeries. Defibrillation can be performed on a patient with an implanted device. Position the defibrillation pads on the patient's chest to avoid contact with the device. Some devices and surgeries may observe in the field include cardiac pacemaker, implanted defibrillators, ventricular assist devices, cardiac bypass surgeries. These ventricular assist devices are getting more and more popular. They allow, like in those patients who have left ventricular heart failure, they basically take over the function of the left ventricle and pump the blood through the heart, through the body. So quality improvement involves multiple functions: medical direction, initial training, maintenance of skills, case review, trend analysis, and strengthening the links in the chain of survival. So maintenance, we're going to use a checklist at the beginning of every shift to ensure you have all supplies and AED is functioning properly. Make sure battery is charged and you have a spare with defibrillator. Okay. Mechanical devices assist EMTs to provide high quality compressions. Using the Lucas CPR device, we have one on every single truck in our service. They are phenomenal, and they save a lot of backs. They save a lot of injuries. So there's also what they call an auto pulse. It's just another device by Zoll. So once you start resuscitation, you must continue until one of these three things occurs, okay, or more. Spontaneous circulation occurs, where the patient gets a spontaneous pulse back. Spontaneous circulation and breathing occur, and another trained rescuer can take over for you. Criteria to determine when it is reasonable to stop without missing anyone who has a chance of survival. Arrest not witnessed by EMS personnel or first responders, and no return of spontaneous circulation after 3 rounds of CPR and rhythm checks with an AED. You can also stop CPR when the AED did not detect a shockable rhythm, and did not deliver any shocks. Okay. So all of these videos are on your My Brady Lab. So, all right, chapter review. Chapter review. Because of these possibilities and the severe complications of heart problems, it is important to have a high suspicion and treat patients with these symptoms for ACS. The treatment will not hurt them and even may help them. Patients with suspected ACS are hypoxic or short of breath, need oxygen, and prompt safe transportation to definitive care. You may be able to assist patients who have their own nitro, and doing so, you'll relieve pain and anxiety. To provide the maximum chance of survival for patients in cardiac arrest, EMS agencies must strengthen their performance of the chain of survival, immediate recognition and activation, early CPR, rapid defibrillation, effective ALS, and integrated post-cardiac arrest care. The heart is a simple pump that moves deoxygenated blood to the lungs and oxygenated blood to the body. Pressure within the cardiovascular system is critical to the moving of blood. ACS is a blanket term that refers to a number of situations in which perfusion of the heart is inadequate. And although there are common symptoms of ACS, EMTs must recognize atypical findings and err on the side of caution. Oxygen, nitroglycerin, and aspirin are key medications indicated to treat ACS. However, the definitive treatment is transportation of the patient to a facility that can open that blocked artery. Most cardiac conditions are caused by arterial problems. Angina pectoris and acute MIs are caused by inadequate perfusion of the heart. Okay. Heart failure can be caused by either electrical or mechanical problems. The most important element of cardiac arrest care is the administration of high-quality chest compressions. The American Heart Association's chain of survival describes the key elements necessary to maximize the cardiac arrest patient's chance of survival. The AED provides early defibrillation in cardiac arrest patients with VTAC and VFib. Post-cardiac arrest care is essential. Mechanical CPR devices can provide automated chest compressions in cardiac arrest settings. All right, so questions to consider. Again, I'm not going to go through these. We're not going to answer them, but I do want you to answer them just in your head as you continue studying for this this lesson. So what position is best for a patient with difficulty breathing and a blood pressure of 100/70? Or what position is best for a patient with chest pain and a blood pressure of 180/90. Describe how to clear a patient before administering a shock. List 3 safety measures to keep in mind when using an AED. List the steps in the application of an AED. Alright, so let's do some critical thinking. You have a 78-year-old male who has severe shortness of breath for 20 minutes prior to your arrival. When you arrive, you find the patient unconscious and not moving. What are your immediate priorities? So our immediate priorities are cardiac arrest, is probably what's going on here. So what we're going to do is we're going to check for a pulse, we're going to check for breathing, we're going to check the airway, we're going to open up the airway, we're going to start CPR probably immediately depending on what we find, and attach that AED, okay, as soon as possible. All right. If you guys have any questions, let me know. You can call me, email me, text me, and I will answer those questions. And I will see you in the next lecture.